Hello and welcome to Season 2, Episode 20 of the Physician Assistant Exam Review Podcast. This episode, we're going to be talking about myocardial infarction. My name is Brian Wallace. I'm the host and creator here at physicianassistantexamreview.com. You can find all the notes, all of the past shows, everything over on the website. So I encourage you to go check it out over there and the podcast. Thank you so much for being with me today. I really do appreciate each and every one of you turning out. The continued growth of the show has been really nothing short of amazing to me. And it's largely due to you guys spreading the word, telling other people as you come across them, either classmates or people on rotations or people you work with, telling people about the show and how valuable it's been to you. And that's really how this show has grown the way that it has. So I can't thank you enough for that. This week we're going to be talking about myocardial infarction. We talked last week about ischemia, and that rolls right into it. I'm going to try something a little bit different for a couple of weeks here. Normally I do a show every 2 weeks. It's a little bit longer. This last week's show I did a little bit shorter. And what I thought is maybe I'd break out topics and make each show a little bit shorter, but make one every week. That way it would give you guys a chance to think things through, to not get lost in the audio, but to still have the same amount of material coming out. So I think that might be something I'm going to test for a little while. If you want to let me know, you can reach out to me, bwallace at physicianassistantexamreview.com, and let me know what you think. So let's jump right in with our priming questions for this week. Let's go ahead and get started with those. When does Dressler syndrome occur? When does Dressler syndrome occur? 1 to 2 weeks post-MI. We'll talk about Dressler syndrome today. I just want you to think it through. What percentage of MIs do not complain of crushing chest pain? What percentage of MIs do not complain of crushing chest pain? It's roughly 30%. What is the hallmark of an MI on an ECG? When you see an ECG with this, it means myocardial infarction, right? So what is it? ST elevation. All right, cool. So myocardial infarction is an ischemic event affecting the cardiac tissue. So we talked about ischemia last week. It's just when there's not enough oxygen being supplied to the tissue, it starts to die. Well, in this case, we're talking about that occurring within the heart muscle. So the cardiac muscle is dying due to insufficient supply of oxygen. We also talked a little bit about how the oxygen need of the heart goes up and down. It doesn't always require the same amount of oxygen. If it's working harder, it requires more oxygen. If it's not working as hard, it requires less oxygen. That's why things like beta blockers will help reduce the oxygen need of the heart muscle and thereby help alleviate angina and things like that. And even you'll see we'll be using those to treat myocardial infarctions and for post-op care, or not post-op, I'm so stuck in the OR. For post-MI care, we'll be using beta blockers. These reduce the need of oxygen for the heart because it reduces how hard the heart is working. Causes of MI, most commonly it's a thrombotic event which occurs at the site of a pre-existing plaque causing a complete blockage of an artery. We've talked about thrombotic events before and embolic events. This is damage to the vasculature, which then over top of a plaque, which gets built up within the vasculature, and then it winds up clogging things. Or you get an embolic event where something travels downstream and gets stuck in an artery or stuck in a vessel that is already narrowing. Those are the most common ways we wind up with an MI. Vasospasm is also a possibility. Severe hypotension, excessive metabolic demand. Less often, it can be an embolic event like we just talked about. And then again, cocaine use. You're going to think about that, especially as the test is concerned. You're going to think about cocaine use in a very young individual. So if you have like a 22-year-old who has a heart attack, you might be thinking about cocaine, not about an embolic or a thrombotic event. And again, we talked in the last episode about severe hypotension, how that can cause, again, we're just not delivering enough blood. That's what you need to not enough oxygen. So if we're not delivering enough blood to the cardiac tissue, we're not delivering enough oxygen. And again, I know this sounds really simple, but that's kind of what I do here. The blood that passes through the heart is not what's feeding the heart tissue. It's not what's feeding the delivering oxygen to the muscle of the heart, right? So it's those cardiac vessels that are delivering the oxygen. So if those get blocked off, that's when the heart doesn't get enough oxygen and the heart tissue starts to die. That muscle tissue starts to die. Risk factors. So being male, you have an increased risk. Advancing age provides you with an increased risk. Smoking puts you at an increased risk for everything. A family history of heart issues, hypertension, diabetes, and dyslipidemia. So again, that bottom rung pretty much puts you at risk for everything, and it's a list you're probably well familiar with. Clinical presentation. So our obvious clinical presentation is that crushing chest pain, increasing in severity and lasting longer than 30 minutes. So the patient comes in with the Levine sign we talked about last week. See if you can remember what that was. Crushing chest pain, just feeling terrible weight on their chest, like an elephant sitting on their chest. Now, like we said earlier, about 33% of patients do not have chest pain. So this is going to be, think about women or patients with diabetes who may have some neuropathy and things. They may not show crushing chest pain as their main presenting sign. So pay attention, even especially in those populations with people who complain of things like indigestion, because that's certainly on our list of clinical presentations for MI. They also often occur early in the morning. This has to do with hormone levels spiking early in the morning. The patient may present with diaphoresis, weakness, anxiety, syncope, restlessness, dyspnea, and nausea and vomiting. Those are all clinical presentations. So the way the patients will show up to the ER or to wherever they're going. Again, that crushing chest pain is the one that jumps off the table at you or jumps off the page at you, but all of those others are certainly possible and may be hidden in test questions, so pay attention to them. I could see very easily writing a question with a female complaining of indigestion, but she's feeling very weak with some anxiety and some maybe a little diaphoresis, and you've got to pull out that she's having an MI. It seems like a pretty, like I would feel tricky writing that question, but it would also be pretty straightforward. Physical exam findings. So the patient here may be hypertensive or hypotensive. So remember, we could have a patient who has high blood pressure, which could be a presenting factor, not a presenting factor, a clinical risk for MI, but also if I have a patient who's bleeding out and they could be very hypotensive or very dehydrated and the heart's also not getting enough oxygen. So they can be hypertensive or hypotensive. In the same bent, they can be tachycardic or bradycardic. Now, these kind of don't help you when you hit a test question. So you want to separate these out. As I read through these and I go through the different physical exam findings, the different clinical presentations, what I try to point out to you is the things that will stand out in a test question, the things they have to tell you in a test question. So remembering that they can be hypertensive or hypotensive in a myocardial infarction doesn't really help, right? It doesn't differentiate from anything else. So I sort of discount a lot of that stuff, and I look for the things that are very clearly going to be associated with an MI. And again, there's nothing great here, but that's how I go about studying. That's how I go about thinking about these questions and how I study and how I look at the information. The lungs may be clear or have rales or wheezing. Again, not super helpful. They may have JVD, softened heart sounds, and S4 gallop. That may be helpful because you don't see that in a lot of places. Now, after 12 hours, a fever may develop, and after 24 hours, a pericardial friction rub may develop. Dressler syndrome, which we talked about at the beginning, is a post-myocardial infarction syndrome. It occurs 1 to 2 weeks after an MI. It involves pericarditis, fever, leukocytosis, pericardial effusion, and pleural effusion. So that's Dressler syndrome. It occurs about 1 to 2 weeks after an MI. Pericarditis, pericardial effusion, pleural effusion, fever, and leukocytosis. Again, just pretty easy to write a test question on. Labs and studies. We do serial cardiac enzymes. There's a couple in particular that, again, will probably show up. Myoglobin being the first, this elevates the quickest in the first 1 to 3 hours. It peaks at about 6 to 7 hours and is normal again by 24 hours. This is not as specific as some of the others, but because it reacts so quickly, it can be helpful. Then we have our cardiac troponins. They elevate within 2 to 12 hours, peak around 24 hours, then return to normal in about 2 weeks. Then CKMB will elevate within 3 to 12 hours, peaks around 24 hours, and normalizes in 72 hours. So these help to tell us if we've had a heart attack, and they also help to tell us when the event may have occurred. Now, what I'm going to do is, if you head over to the website for this show, I'm going to put together a little worksheet and a little graph on how to to make sure that you memorize this information. I think that in particular is one I've always struggled with, is which one does what times do I need to know? I'm going to put something together that's going to make it really quick, really simple, really easy for you to memorize that, and then you'll be done with it. Yeah, it's probably only going to be one question on your exam, or maybe not even, but if you grab that worksheet, you'll get that one right. You'll be able to put this out of your head, because that's more important to me, actually, than you getting this question right, is that you don't get hung up on these. Because the ones with the numbers like this, it's easy to mix them up, and it's easy to give you a little anxiety. So I'm going to clear that up for you. Head over to the website. I'll have a link there that'll be pretty easy to follow, and you'll be able to download that worksheet, and it'll be pretty. I'll make it really straightforward, really simple, and I'll have a couple of questions involved there. You'll do a little quiz, and it should be something that never leaves you. And if it does, you just pull this out again, so you don't have to worry about it. All right, on ECG, progression from peaked T waves to ST segment elevation to Q waves to T wave inversion. ST elevation is defined as greater than 0.1 millivolt. On a 12 lead, you may be able to determine the location of the infarct by the leads that show the changes. So we talked about this before. If you have a pericarditis, you have an ST elevation in all the leads, but if you have an MI, it's going to be in these specific patterns. So this is something that you should definitely know, but I'm not going to cover it in a ton here, because in audio it's a little bit awkward. And it's something you can find in lots and lots of places, and something you probably spend tons of time on. In your inferior leads are lead 2, 3, and AVF. That's an inferior MI. Your posterior leads are V1 and V2. Anterior septal are leads V1 and V2. Anterior is V1, V2, and V3. Anterior lateral V4, V5, V6. And again, I don't want to spend a ton of time on that here, because you can get that in so many other places. The chest X-ray may show signs of CHF. You may want to get an echo and a catheterization. Treatment. Approximately 50% of deaths from an MI occur before the patient ever reaches the hospital. Just something to keep in mind. Approximately 50% of deaths from MI occur before the patient reaches the hospital. Aspirin 162 milligrams or 325 milligrams daily starts immediately. Clopidogrel, or also known as Plavix, 300 milligrams oral, given once as a loading dose, and then titrate down to about 75 milligrams a day. That's going to be another blood thinner that's going to help us. Nitroglycerin is going to be something more immediate. Vasodilator helps to relieve ischemic pain, like we talked about last week. Morphine for pain control if nitroglycerin is not effective. Enoxaparin is better than heparin, and significantly reduction in death and MI at day 30. So something to consider. You may also want to give thrombolytics. This is something that should definitely come up on your test. This is the most effective within the first 3 hours. It has a 50% reduction in mortality. Patients should be treated up until 12 hours after onset of symptoms, and then there's only a 10% reduction in mortality. So one of the big keys with thrombolytics, so that's breaking up the thrombus, right? A thrombolytic, it breaks up the thrombus. So what we're trying to do with our aspirins, our clopidogrels, our thrombolytics, is the aspirin and the Plavix will stop you from creating new clots, right? The nitroglycerin will help with the pain, open up the vessels, let more blood flow through. The morphine will help with the pain. It helps to drop your blood pressure if you're not in as much pain. And the enoxaparin, the same thing. They help to not form new clots. Now, the weird part is, and as you learn more about this and wrap your head around it, you already have the clot, right? You already have something blocking the artery, so that's where the MI comes from. All those other medications prevent new things from adding to it and making things worse. It's the thrombolytics that actually break up the clot that's there. Okay, so our TPA breaks up the clot that's there, but it's only effective if done right away. And that makes sense because the heart tissue is dying over time. So at 12 hours, that heart tissue has really been affected already. So breaking up the clot after 12 hours, you get a 10% reduction in mortality. That's great, but obviously we've done a lot of damage by then. It's most effective in the first 3 hours with a 50% reduction rate in mortality. So that's really important. Is if you're going to use the thrombolytics, they need to be done as soon as possible. So reasons to use thrombolytics: ST elevation suggests acute coronary occlusion warranting reperfusion. We no longer use streptokinase in the US, but that was like the first one we used. It's more the tissue plasminogen activator. TPA is the one that you'll hear the most about. An easy list to ask questions on are the contraindications for thrombolytics. The contraindications, so this would be the reasons not to give thrombolytics. So when we talk about contraindications, let me just be clear that what we're really talking about is the idea that some of the things. Sorry, I have some. Okay, sorry, I had some equipment malfunctions. I'm not sure exactly what happened. I'm trying to fix it as I go here, but I sort of lost audio a little bit there. Okay, where were we? We were talking about contraindications for TPA. So one of the issues with TPA is the contraindications. It's such an easy thing to write test questions on. It's a simple thing to know. And the basic idea is that you should not give TPA to anybody who's got a serious issue with bleeding, right? Because we're breaking up clots. We're making it so they don't form new clots. So if there's an issue with them bleeding, we don't want to give them TPA if it could make them worse. So contraindications are really simple. You don't actually have to memorize this list. You just have to understand that. We don't want to make a situation where the bleeding is worse than the MI was. And how we're going to do that is we're going to avoid things like, so here's our list. A stroke within 1 year, a stroke within the previous year, you're not going to do TPA. If they have an intracranial neoplasm, you're not going to do TPA. Recent head trauma, active internal bleeding, that seems like a contraindication to giving them something that will cause them to bleed more. And then concern of an aortic dissection. Those are your contraindications. Now, there's also a list of relative contraindications. And again, these are things that so this makes you want to avoid TPA, but doesn't preclude you from using it. Blood pressure greater than 180/110, intercerebral pathology, trauma within the past 2 weeks, major surgery in the past 3 weeks, if the patient was given CPR lasting more than 10 minutes, pregnancy, and current use of other anticoagulants, because you don't want the compounding effect. So what you're looking at here is a list of reasons why a patient is already bleeding or has an issue where they may be bleeding. And the worse, the more severe that may be, the less likelihood you're going to want to give TPA. So that's our contraindications and our relative contraindications. Let me run through the list one more time real quick. Direct contraindications, stroke in the previous year, intracranial neoplasm, recent head trauma, active internal bleeding, and concern of aortic dissection. Relative contraindications, blood pressure greater than 180/110, intracerebral pathology, trauma within 2 weeks, major surgery in the past 3 weeks, CPR lasting more than 10 minutes, pregnancy, and current use of anticoagulants. And that all makes sense, right? We don't want them to bleed and kill them with TPA and while we're trying to save them from the MI. Another treatment is going to be percutaneous coronary intervention, PCI. This is a catheterization and stenting, which has been shown to be better than thrombolytic therapy when performed by experienced people and in a high-volume center. One big key to this is a door-to-balloon time. It has to be less than 90 minutes. So by the time the patient hits the door to the ER, and then the time the balloon goes up has to be less than 90 minutes. And then, of course, we have our coronary artery bypass grafting or CABG. That is the procedure to actually go in and replace those vessels rather than opening them up to go in and replace them with other vessels so that the heart then has a new pathways to bring blood in, and we bypass the affected areas. All right, so that'll cover MIs for today. Excellent. Let's move on to our study tip. And our study tip for today is a service called freedom.to, freedom.to. It's a website. It's an application that I came across. I passed it out to the email list last week. And what this service does is, I haven't actually subscribed to it. I'm very tempted to, but I think for a lot of you, you may find it extremely valuable. And what this service does is it allows you to set up a system to block yourself from getting on the internet, to block yourself from using certain applications. Now, you can do it a couple different ways. You can block the entire internet. You can block certain applications, like I just don't want to see Facebook for the next 2 hours. And you can schedule when you are allowed to use those apps or to use the internet as a whole. And this can be used on your computer, it can be used on your phone, it can be used on any device, and that's kind of the beauty of it. And one of the places I thought it might be really useful for me would be to, I do a lot of work in the mornings. I get up at 5 and I usually write or do something from 5 to 6. But sometimes I get distracted and I start doing things that aren't the most productive during that time. So what might be really helpful is to set this up the night before when I'm in a good mindset and I've got a good frame of mind, because making these decisions outside of the moment is always better, right? So like packing your lunch the night before, planning out your meals on Sunday for the whole week, you always make better choices than you would in the moment when you're hungry, when you don't want to do your work. So you could set this up the night before to say, block out all the games on my phone from 5 to 6 tomorrow morning. And then it would keep those games locked, and you wouldn't be able to use them from 5 to 6 tomorrow morning. And it takes the willpower out of this situation. Like I said, I haven't played with this much, but I think it's a great idea, and I think it could be really valuable, especially when you're trying to study and you're just like, let me just check Twitter for 1 minute. Let me just check Facebook for 1 minute. I'll be real quick. And then 2 hours later go by and you're on cat videos and YouTube and you're down a rabbit hole all over the place. And you're just like, man, I don't have enough time to get through my studying. I don't know how everyone else does it. The answer may be that you need to get the phone turned off. You need to get the computer turned off. But it's hard because sometimes you need to study with certain applications. Sometimes you need to study with the internet. But this allows you to go in and selectively pick which tools, or not tools, which apps, which things you should not be using during certain periods of time. So go check that out, freedom.to. The people at Focus at Will sent out an email to me pointing it out, recommending it. And you guys know how much I like Focus at Will. I use that constantly. Really love their system. So it's definitely something worth checking out. And I may go ahead and sign up for it. If you do go ahead and sign up for it and you like it or don't like it or whatever, just shoot me an email. I'd love to hear about it and share your experience with everybody here on the show. All right, so let's move back into let's finish up with our questions here, with our post questions. When measuring myoglobin after an MI, when is it first elevated? When is the peak? And when does it return to normal? So for all 3 of our cardiac enzymes, we had a number for first elevation, for peak, and then for return to normal. What was it for myoglobin? Remember, that was the shorter acting one, so use that to help you remember. If you're not driving, write something down. If you're driving, say it out loud so that you actually have to commit this and give it a shot instead of just listening along and pretending like you're getting something out of it. Actually give it a shot. First elevated, peak, and normal. It is first elevated at 1 to 3 hours, peaks at 6 to 7 hours, and returns to normal at about 24 hours. Remember, if you, I'm going to set that up on the website for a quick review sheet on how to remember those, couple of questions and things. Definitely go check that out. How soon should, I just have it written funny in my notes. I have TAP. How soon should TPA be given? What's the time frame for how quickly we want to give TPA? And again, that's within 3 hours. Remember, we've got an ischemic event going on. So tissue is dying. We want to make sure that we open that up and reperfuse it. Within 3 hours is our goal. 90 minutes to balloon time was our key. Oh, I'm sorry. That was 2 different things. Within 3 hours is our goal here. We want to get that reperfusion going. And when we hit 12 hours, we're down to a 10% effect on mortality. When does Dressler syndrome occur? When does Dressler syndrome occur? That was from the beginning. When does Dressler syndrome occur? And that's at 1 to 2 weeks post-MI. All right, well, that'll wrap us up for this week. Thank you so much for tuning in. We will continue with cardiology next week. Good luck to all of you who are taking your exam in the interim. And definitely go check out the website. Sign up for the email list. There's so much good information that I send out through that. So definitely go over and check that out in general. But more specifically, go to today's episodes, Season 2, Episode 20 on myocardial infarctions, and look for the little activity sheet on cardiac enzymes. All right, take care, good luck, and I will talk to you next week.